So my oration is on a walk through the abortion law and its amendments. And the way I've structured the presentation is that we'll first start with a little background on the abortion laws. We will then talk a little bit about the current act. We will then talk a little bit about some laws which conflate and conflict with the MTP Act. And then lastly, we will talk about the amendments. Venu and Subhash, I think I have 30 minutes. So if you could just let me know 5 minutes before my time is up, because I do get carried away when I speak on this topic. So let me begin this presentation with a story. And this is a story I have talked about several times, and every time I talk about it, for me at least, it drives home why safe abortion is so important. I'm going to ask all of you to, for a minute, just close your eyes. Just close your eyes. Imagine this small village somewhere in our country. There is this small family, father, mother, and daughter. Daughter is 12 years old. The father and the mother are daily wage earners. Every day they have to go to the fields to work. And when they do, they leave their 12-year-old daughter with someone whom they think is a trusted relative, the maternal uncle. Unfortunately, this trusted relative turns out to be the worst kind of predator, a pedophile. He repeatedly rapes this 12-year-old girl until inevitably she gets pregnant. Not having had the benefit of menstrual hygiene education or sex education or whatever you would like to call it, she doesn't realize that she's pregnant. After a few months, her mother realizes that my daughter has not had periods since a few months. So she takes her 12-year-old daughter to the primary health center of the village, only to be told that 12-year-old girl is 24 weeks pregnant. Now I want you to just imagine, think for a moment what this family is going through. If this were not enough, they are also told, because this is before the amendments got passed, that I'm sorry, we cannot do an abortion for you. The limit for providing abortions at that time was 20 weeks. And so you will now have to start going through all the rounds of various authorities and lawyers, courts, judges, etc. So they start going to all the authorities, the district court, high court, sessions court, and finally Supreme Court. And what I would like you to imagine is how every time they go before a new person, a new board, a new lawyer, a new judge, they are reliving that trauma of the multiple rapes that this 12-year-old encountered. They finally reached the Supreme Court, and this is where I got involved. I was asked for an opinion on this case by the Supreme Court on whether she should be provided an abortion or not, and I said, yes, of course she should be provided an abortion. But at that time, she was 32 weeks pregnant. It took her from 24 weeks to 32 weeks to finally reach the Supreme Court, and the Supreme Court said, well, she's relatively healthy, the fetus is healthy, so we are not going to give you permission to do the abortion. This 12-year-old then had to be admitted to a tertiary care hospital, where at 37 weeks she delivered a baby girl by cesarean section and then gave it up for adoption. The reason I'm telling you this story is that we have normalized MTP to such an extent in our country that we don't really look upon it as a problem. I can share my personal experience and say that when I was doing my residency, going to the MTP OPD and doing MTPs was something which was taken for granted. I did not even realize that there is something known as unsafe abortion. And that is why whenever we talk about MTP in this country, whenever we talk about abortion in this country, I want you to keep this 12-year-old girl in your mind. Because her and countless others who suffer because of the lack of safe abortion have their lives completely upended by this problem. Of course, how we provide abortions depends on the law. And it's rather unfortunate that as obstetricians and gynecologists, we are actually the most regulated specialty in medicine. I don't know if you realize, but we have actually more laws and policies governing us than even cardiac transplant surgeons. Obviously, it means the government thinks that delivering patients, providing abortions, and doing hysterectomies is much harder than doing a cardiac transplant. And that's why we got so many laws governing us. But because of the way the laws that govern us are written, quite arbitrary sometimes, quite draconian sometimes, we as obstetricians, gynecologists, physicians in general, have developed a very healthy cynicism or skepticism about the law. We don't think about law as something that we should be engaging with. It's like the attitude which Hermione had in one of my favorite book series, Harry Potter. And in the Deathly Hallows, Scrimgeour asks Hermione, "Are you planning to follow a career in magical law?" And she says, "No, I'm not. I'm actually hoping to do some good in the world." Now, this is a fairly old quotation which I'm very fond of, but I suppose karma gave it back to me because my elder son is now pursuing law. Because of the general cynicism or skepticism, I suppose, we don't look at the laws which govern us. I'm not asking for a show of hands, but just think to yourself. How many of you have actually read the MTP Act cover to cover? How many of you have read the ERT Act cover to cover? How many of you have read the PCP-NDT Act cover to cover? Because of all this general cynicism and skepticism which surrounds the law, unfortunately, laws remain something what Mark Twain said about a classic, something that everybody wants to have read and nobody wants to read. And so it's really quite important to know all the laws that govern us, and at least for the MTP Act, the genesis of the Act, the context of the Act, comes from how the Act has evolved over a period of time. Why was the MTP Act needed in the first place? And the genesis is actually way back in 1860, when the Indian Penal Code was promulgated by the Britishers in our country. And with all its Victorian morals and mores, etc., what the Indian Penal Code does even today is criminalizes abortion. These two sections of the Indian Penal Code make both providing abortion as well as seeking abortion a criminal act. Because of this, obviously, abortion went underground. And when an activity around health which is so important goes underground, morbidity and mortality from it rise. Way back in 1964, the government realized this and set up what was called the Shantilal Shah Committee. Mr. Shantilal Shah was a retired bureaucrat from Mumbai. So they asked him to head a committee in 1964 The committee worked for 2 years and produced a report in 66, which was known as the Shantilal Shah Committee report. And that paper that you see over there is a page from the original Shantilal Shah Committee report of 1966. I got it when I had gone to Parliament to make a presentation to the Rajya Sabha. And I got it from the Library of Parliament. And I've circled in red over there. Foxy was represented in the Shantilal Shah Committee at that time. And it was Dr. V.N. Shirodkar who very ably represented Foxy at that time. You know, we are very fond of Shirodkar's stitch and Shirodkar's sling and so on and so forth. But I think that with this one representation in the multiple meetings which Shantilal Shah Committee had, Dr. V.N. Shirodkar actually touched many more lives than he did with all the operations that he had devised in gynecology. The act was finally notified in 1972. But what is important to realize is that the way we provide abortions does not depend only on the act. So the act is an act of the government. This is then followed by the rules, which are framed by the central government and ratified by each House of Parliament. And in fact, sometimes rules can have a much bigger impact on our practice than the act itself, and I will illustrate that in the next slide. This is then followed by regulations. Remember, in India, because of our federal structure, health is a state subject. So whenever the center makes a policy on health, states have to be given some say. And in the MTP Act, they are given a say via the regulations, but this say is restricted only to opinions and reporting and maintaining secrecy. And then finally, there are the SOPs from the central government. So how we provide abortion depends on the act, it depends on the rules, it depends on the regulations, and it depends on the SOPs. And medical abortion, for example, is something which was introduced in this country because of that one paragraph that you see in the rules of 2001-2002. Medical abortion is not mentioned in the Act anywhere. We use mifepristone and misoprostol because of that one paragraph in the rules. In fact, in our country, over 75% of all abortions now take place through mifepristone and misoprostol. And this is what I was saying when I meant that sometimes the rules have a bigger impact than the Act itself, because medical abortion is available in the country because of the rules and not the Act. Second trimester abortion with mifepristone and misoprostol is possible in this country because of the SOPs. SOPs from the central government in 2014 referenced the WHO guidelines and said BFI and meso is the safest way to provide second trimester abortion. And that's why we continue to use MIFI and meso for second trimester. Of course, it helps when professional organizations like Foxy come out with good, well-meaning guidelines. You can see on top there, Foxy ICOG GCPR for MTP, which I had the good fortune of drafting when I was the chair of the MTP committee in 2004. And I'm quite happy that these guidelines have even stood the test of time now. So I hope I've contextualized the importance of the Act and a little background of the Act for you. I'll move on to now some well-meaning acts which cause unnecessary conflation with a good act like the MTP Act. A prime example is the PCPNDT Act. If you really look at it very legally and correctly, the PCPNDT Act and the MTP Act have actually nothing to do with each other. There is, however, conflict which has been created in a way because of the way that the PCPNDT Act is implemented. The authorities sometimes seem to think, and I'm not painting all the authorities with the same brush, but some authorities seem to think that let's reduce abortions. That will reduce gender-selected abortions and therefore normalize the ratio. And this is a completely fallacious thinking. And I've had several arguments about this with activists, radiologists, heated arguments with radiologists, because they keep on saying the abortions are responsible. And I always tell them that no. If there were no gender determination, there would not be any gender determined abortions. It's as simple as that. The problem lies upstream and not downstream. The POCSO Act is another classic example of how a needed, well-meaning act can actually make things more difficult for providing abortions. Before the POCSO Act, the MTP Act was actually very friendly towards adolescents. The MTP Act essentially says that if somebody below the age of 18 needs an abortion, that person can access abortion provided she is accompanied by a guardian. And this is the importance of word. It doesn't say legal guardian. For the purposes of the MTP Act, the guardian could be anybody above the age of 18. It could be elder sister, elder brother, or even her boyfriend if he is more than 18 years old, and that's perfectly fine. But then the POCSO Act came. And in a sense, what the POCSO Act did was took a very protectionist approach, a very Mai Baap Sarkar kind of an approach. It seemed to tell adolescents that we don't trust you with your hormones, we don't trust you with your sexuality, and therefore we are going to ban all criminal activity below the age of 18. So anybody below the age of 18 indulges in any kind of sexual behavior in our country, it's illegal, criminal, and liable for prosecution. Not only that, there is an aid and abetment clause where anybody who aids and abets can also be prosecuted. And this is a very funny thing. I understand that governments change, and the POCSO Act was not the act of the present government, but the present government has this beautiful RKSK document. Both of these documents, the scary-looking POCSO document and the RKSK document, are available on the same website of the government. And yet, look at the conflict and conflation. The POCSO Act says all sexual activity below the age of 18 is criminal. The RKSK document, on the other hand, says, of course, adolescent sexuality exists. Of course, adolescents have sex, and they must have access to contraception. And this conflict and conflation has created a lot of confusion in the minds of anybody who is a service provider. So I just thought I'll dwell on three things which I get asked very often by service providers. Does a provider have a legal duty to inform the authorities if a minor girl is pregnant? The answer is unequivocally yes. Even if the girl has not expressed a desire, even if the girl is a married minor, and even if the girl's age is uncertain, you have to report to the appropriate authority. Most of the times, the appropriate authority is the police. There are, however, some districts in some states which have child services. How do you inform them? On your letterhead, you write, Miss So-and-so, age about so-and-so, has come to see me, and I find that she's so many weeks pregnant. Take 2 copies, take received on 1 copy and come back to your clinic. Once you have informed, your duty as a provider under the POCSO Act is complete, and you and the girl now move from the POCSO Act into the MTP Act. So do you have to wait for any medical legal procedure before performing the abortion? The answer is absolutely not. Unless and until the authority to whom you have informed or the court tells you don't do the abortion, you go ahead and get the abortion done. Do you have to preserve the products of conception? Now, this is a very contentious and controversial topic, but we recently had a consensus which was organized by the Jindal Global Law School, where retired Supreme Court lawyers and judges had come, and all of them seemed to say that it is not necessary to preserve products of conception in this case unless and until you have been expressly told in writing to do so. So this was the last time the Act got amendment, 2001-3. I was quite fortunate to be a part of the amendment at that time. And in fact, I've been very lucky to have had a role in the current amendments also. This is a slide shot from my calendar, screenshot from my calendar. And the reason I'm showing you this, look at the date, 6th October 2008. And the reason I'm showing you this is because of what happened on that day. MTP amendments meeting at the Ministry of Health and Family Welfare, Delhi, 2008. This was one of the first meetings, official government meetings. There were several meetings before that, but this was one of the first official government meetings I had attended for the amendments. That's how long it has taken to get the amendments in. Of course, a lot of hard work has gone into it. These are some of the articles that I have written in support of the amendments. That's an article in the Hindustan Times, Mumbai Mirror. That's an op-ed in the Hindu. I have been interviewed by law journals. I've published in law journals. This is an excerpt from an interview where I was interviewed by the Jindal Global Law School Journal for my views on the conflation between MTP and PCPNDT. I've published in the International Journal of ONG on the need for amendments. And as I said, I've made presentations to parliamentarians. And the point that we made to the parliamentarians at that time was that the question of abortion should not be an issue in the political arena. When a woman has to make this kind of decision, she should be able to see her doctor, not her lawyer, which is what was happening at that time. We also visited the Prime Minister's office. This is when I was Secretary General. You can see that's me, Jaydeep and CN sir standing outside the PMO. We didn't meet the Prime Minister, but we met the person who was in charge of health in the Prime Minister's office, and we conveyed to them that all these are urgently needed to make the Act in tune with times and more rational and reasonable. We were therefore actually very pleasantly surprised that when the MTP Act was finally tabled in the Parliament, in the Lok Sabha, they had accepted all our requests or asks, except the first one, which was making abortion a woman's right. In fact, and I'm not sure you can hear this, this is Dr. Harshvardhan speaking in the Rajya Sabha. And I think for the first time ever, Foxy was mentioned in the Parliament as a significant stakeholder in women's health and who was consulted first before making the amendments to the MTP Act. So these are the amendments notified, etc., and I'll take you through them quickly. Just for your reference, what is in orange are the amendments made in 2002 and 3. What is in red are the current amendments. So what is in red is what we will focus on. The amendments first say that you need to form a medical board, and in an underrated change for the first time, in so many years, for the first time after 72, the Act mentions the methods of providing an abortion. Till now, the Act did not mention that we could provide an abortion medically or surgically. Previously, you needed one opinion from 0 to 12 weeks and 2 opinions from 12 to 20 weeks to provide an abortion. This has changed in a fairly important change. Right up to 20 weeks now, only 1 opinion is required. And between 20 and 24 weeks, you have 2 opinions which are needed. Another change, which seems to be minor but is actually quite important, is dropping the word married from the clause for failure of contraception. This is important in a societal context because with the dropping of that word married, the government has now accepted that unmarried women also have sex, they also have unwanted pregnancies, and they also need safe abortion. Within the Act itself, the limit for gestational age has been increased to 24 weeks for the incidence of rape. The next 2 changes that I'm going to show you, in my view, actually make India's abortion law perhaps the best in the world as it stands now. If you look at who is allowed to undergo an abortion in India right up to 24 weeks, this is the list of indications: survivors of sexual assault, minors, right down to women with pregnancy in humanitarian settings. And if you think about the indications of the original Act, you'll realize that the only indication for which women cannot undergo a termination up to 24 weeks in fact, is failure of contraception. For everything else, abortion is now legal up to 24 weeks in our country. The formation of medical boards is also a significant step. Let me reiterate. Up to 20 weeks, things remain as they were. 20 to 24 weeks, the indications I showed you. Medical boards come in only after 24 weeks. Before 24 weeks, there is no need to go to the board. After 24 weeks, and only for the indication of fetal anomalies, do you have to go to the medical board. As you can see, it's fairly easy to constitute the board, but in a very classic example of the gap between policy and implementation, despite the Act having been notified for quite some time now, almost no state has notified a medical board. No state. In fact, this is a couple I helped with from Delhi. So I got a call from them saying that we understand you work in the abortion space. We have a fetus at 28 weeks with a complex congenital cardiac anomaly, and we want an MTP. I said, that's fine. Delhi is so full of tertiary hospitals. Go ahead and go to the hospital. They said, but sir, there's no medical board. So then I helped them to write their affidavit, etc. We went to Delhi High Court, and on the same day, the High Court asked the government to form a board, and she could safely get an abortion. And this is one crucial change which has occurred. If you have a patient who needs to go to High Court now, don't ask for permission for the abortion. That's no longer the court's, it's no longer in the court's ambit to give you permission. Ask for the court to set up a permanent medical board. That is a significant change. And previously the procedure was go to High Court, and only High Court, no other court would do. The High Court would then direct a medical board to be formed. I'll finish in another 5 minutes. The High Court would direct a medical board to be formed. The medical board would then take its own time. There was no time limit. Give an opinion in a sealed envelope to the judge, and then the judge would finally decide that the abortion should be provided or not. And this has completely changed. Remember that 24 weeks to 32 weeks, it no longer will occur. Now, the medical board is duty-bound to give a report within 3 days of receiving a request. And if the medical board thinks that the abortion is required, then they have to make sure that the abortion is provided within 5 days. It's a really, really remarkable change. A process which used to take weeks and months together has now become compressed into 5 days. There has been some worry, particularly about Section 5A1 and 2, because it introduces penal provisions. But these penal provisions are for breaking confidentiality, and as I told you, opinions and secrecy fall under regulations. So we are still waiting for the government to come out with model regulations to understand the full implications of this. Some training requirements have changed because a new cadre has come in. This is reflected in a change in the opinions, and there are 2 new forms. Form D has to be filled by the medical board, and as you will see, previously sometimes medical boards used to give very equivocal opinions. They would not clearly say that the abortion is allowed or denied. In this form, you have to write allowed or denied, so there is no scope for any ambiguity. And that is the form that we have to fill if we terminate a pregnancy between 20 and 24 weeks. We are, of course, waiting for SOPs. These are the SOPs I had drafted for the government of Maharashtra. They had asked me to help in drafting the SOPs. We have sent them to the center, and hopefully they'll come by soon. After the amendments came out, I was asked by the government to draft an op-ed on the amendments, and I was very happy that they released the op-ed as a press note to all the high commissions and embassies all over the world. So if you visit a whole lot of high commissions and embassies, you'll be able to read my op-ed over there. Now, there has been some criticism saying that perhaps we could have done more with the amendments. You could always have done more. But I've just finished my tenure as the global FIGO chair of abortion, and that's given me a fairly global perspective. And I'll reiterate that I think because of these amendments, the Indian abortion law is easily one of the most liberal and best abortion laws in the world. Compare it, for example, to the United States, particularly after Roe versus Wade has got overturned. There are entire states in the most advanced country in the world, America, where women can't get an abortion. Texas, the largest state in the country, does not have even one abortion clinic. Women are going from Texas to Mexico to get an abortion. Of course, the path from policy to implementation is never straight, as this arrow illustrates. It is fairly tortuous, but we have to navigate it. And we have to navigate it because when done by qualified people using correct techniques, abortion is one of the safest medical procedures. Just think back to your residency. The first procedure that you were given was probably a gynac DNC or an MTP. And for want of such a safe procedure, not to talk about mifepristone and misoprostol, women are still dying. If that is not a tragedy, I don't know what is. We need to stop unsafe abortion. After all, history is her story too. Thank you.